Next up, we've got Arun Azad. He's a medical oncologist from the Peter Mac, and he'll be speaking about giving us a trial update about combination therapy.
Thanks, David, and thank you for the opportunity to speak. It's great to see such a big turnout. So I'm talking about combination studies with radioligand therapy and where we're at. There we go. So, I've gone back. Go back one, I think. There we go. So lutetium PSMA. I think we know we know this slide will be familiar to everyone here. The benefits. It's an active treatment, high response rates, well tolerated, improves symptoms, improves quality of life, and increases survival. But we know there are still lots of challenges. Not all patients respond. Responses can be short-lived, unfortunately. Resistance is inevitable, and the survival improvement is relatively modest. So we still have a lot of work to do. And how can we make radioligand therapy better? And I think these are some of my thoughts: biomarker driven patient selection, novel targets, novel radioisotopes, and then the focus of today's talk, which is combinations. So this is just a list of some of the key combination studies. Obviously, in 10 minutes we can't go through all of them. So if I've left anyone's favourite study off the list, please accept my apologies in advance. But these are some of the key ones in metastatic hormone-sensitive prostate cancer, first-line mCRPC, and then second-line and sort of more advanced mCRPC. So we'll work through this fairly quickly. So in the metastatic hormone-sensitive prostate cancer space, there are two key trials: PSMA Addition, which is a Novartis sponsored phase 3 trial. And so this is patients with newly diagnosed MHSPC who are starting ADT, and then getting standard of care, which is typically an androgen receptor pathway inhibitor, versus an androgen receptor pathway inhibitor plus lutetium PSMA 6 cycles. So I think this will be an interesting study to see when this reads out. 6 cycles is a lot, to give in the hormone-sensitive space, bearing in mind that ADT plus AR pathway inhibitors are very active, and so you may not have any signal by the time you're getting through to 6 cycles of Lu-PSMA. So that'll be interesting to see how that study reads out, with the primary endpoint of overall survival, of rPFS, key secondary endpoint of overall survival. We've also got in the first-line MHSPC space, Upfront PSMA, which is a study that I'm leading with Michael, which will read out this year. So this is similar, newly diagnosed but high-volume MHSPC. Patients were getting ADT plus docetaxel, which when we started the study a few years back was a standard of care for high-volume de novo disease, 6 cycles, and then patients in the experimental arm are getting 2 cycles of Lu-PSMA before starting docetaxel. 130 patients were randomized to this. This will read out this year. The primary endpoint, being a smaller study, is undetectable PSA at 12 months. So this will be interesting to see how Lu-PSMA actually in sequence with docetaxel in this MHSPC space fares. So what about first-line mCRPC? So you would have seen this data from the ENZA-P study, ANZUP Cancer Trials Group sponsored trial and led, of course, by Louise Emmett. And so this is actually taking patients who have progressed and developed first-line mCRPC and were NHA naive, AR pathway inhibitor naive, and randomized either to enzalutamide versus enzalutamide plus lutetium PSMA. A very neat and elegant study design. I can't go through all of that today in the interest of time, but basically the patients were considered poor or high risk based on and predicted to have poor response to enzalutamide. And so the study is looking at whether those particular patients could do well with enzalutamide, but in combination with Lu-PSMA, with the primary endpoint being PSA PFS. And of course, we've seen there's some really nice imaging work that's been built into this for correlative studies, with early PET as a pharmacodynamic biomarker. And this is an example of a slide that Louise has presented previously, showing the very nice response with some early PSMA signal at day 15 PET. And there's also some clinical data that's come through from this already. As we know, this was presented last year at ESMO. It was an oral presentation from Louise, with significant improvements in PSA PFS with the experimental arm of Enza plus Lu-PSMA versus enzalutamide, and also improvements in radiographic progression-free survival as well. So really good study, I think speaks to the potential synergy between AR pathway inhibitors and lutetium PSMA. All right, so we'll go to the second line, and then the second line MCRPC space. So there's lots of studies in this space. We'll work through them. Shaneen Sandhu, who you all know, presented the LUPARP study last year at ASCO, which is a phase 1 trial of lutetium PSMA 617 and olaparib in MCRPC patients. This is being a phase 1 study. It's gone through dose escalation. This is a slide summarising the study schema. Essentially, metastatic CRPC patients post a AR pathway inhibitor. Docetaxel was also permitted, and this is the design that's they've gone through. These are the results. If you look at this composite, basically, high response rates here, PSA 50 response rates of 65%, and some very deep responses, 47% with a PSA greater than 90 response, and then objective response rate by RECIST of 78%. So this study is ongoing with some additional cohorts still being planned, but some really compelling data thus far. Shaneen's also got another study, PRINCE, which you would have heard of, which was the lutetium plus pembrolizumab combination. So again, MCRPC that's progressing after a prior AR pathway inhibitor, and again, prior docetaxel was permitted. This was presented now a couple of years back. And so this study also has shown impressive, impressive activity, 73%. Obviously, it's a single arm study, so we always have to be careful about overestimating the benefit or over-interpreting the benefit of particular treatment, but still impressive response rate of 73%. And this then moved forward to the evolution trial, which I'm going to present on the next slide, with some toxicities that you'd expect from predominantly from immunotherapy, but nevertheless still impressive activity. And this then spurred this is a small slide, the evolution trial, which is an ANZUP sponsored trial again, phase 2 study. What's going on here? Phase 2 study of Lu-PSMA versus ipilimumab plus nivolumab in metastatic CRPC, again post AR pathway inhibitor. We're still waiting for results on that, but really interesting to see the interaction between combined immunotherapy, immune checkpoint inhibitor blockade with lutetium PSMA. And then we move on to the final couple of studies, LUCAB, which is a study combining lutetium PSMA plus cabazitaxel, single-arm study, Peter Mac sponsored study that is ongoing. And this is basically, the thinking here is that we're going to target, potentially PSMA negative or FDG positive disease with cabazitaxel. Cabazitaxel is also, being a taxane, is a radiosensitizing agent and might cause lutetium to work better. So patients are getting 6 cycles of lutetium PSMA and 12 cycles of up to 12 cycles of cabazitaxel in combination, given concurrently. And so we're recruiting up to 40 patients for this. Recruitment's ongoing, seeing some really promising data so far. Obviously the study, nothing we can share yet, but some interesting results we're seeing with this, so watch out for that one. This is the design, and so we being a phase 1 study, we've gone through 4 doses of cabazitaxel in a dose escalation phase with a fixed dose of lutetium PSMA. And the last study is Alphabet, which is lutetium PSMA INT in combination with radium. Some very nice preclinical data supporting this combination. And again, perhaps we can, during the discussion, we can talk about the pros and cons of combining an alpha and beta emitter. But there is a nice rationale for doing that, and so at least we thought anyway. So we're pushing forward with this study, which is also recruiting really well. It's Peter Mac sponsored study, again, single arm study. This is the design. So up to 6 cycles of both lutetium PSMA and radium, which are being given concurrently. In fact, we're giving on the same day, and that study is also recruiting nicely. We're obviously giving bone resorptive, anti-resorptive agents like denosumab or zoledronic acid to patients given that they're having radium. So final thoughts in the last sort of 40 seconds. So I think these combination strategies with Lu-PSMA, as a very quick overview, hold significant promise. But Lu-PSMA is highly active. So beating it in studies like in phase 3 studies, I think will be tough. There are a lot of ongoing combination trials, but I think the question will be whether these studies can actually improve the durability of response and increase survival, which is still a big challenge with radioligand therapy. And lastly, thanks to everyone, particularly Michael, for sharing their fantastic slides. Thank you.